Hello and welcome to another Facebook Live with MedStar Health. My name is Michelle Carter, and today we'll be talking about atrial fibrillation, also known as AFib, the most common type of arrhythmia or irregular heartbeat. I'm joined today by our cardiac electrophysiologist, Dr. Zayd Eldadah and Dr. Glenn Meininger, and our cardiac surgeons, Dr. Bethea and Dr. Shults. 1 in 4 adults over the age of 40 will develop atrial fibrillation in their lifetime. So it's important to learn what AFib is and how to treat it. We have lots to talk about today, so stick around, share this broadcast with your friends, give us a like to let us know that you're watching, and share your questions with us in the comments below. We're going to take some time to answer those as well. All right, so thank you, doctors, for joining us. Before we get started with the questions, could you share a little bit about yourselves and the work you do here at MedStar Health? I'll start with Dr. Eldadah.
Thanks, Michelle. My name's Zayd Eldadah. I'm a cardiac electrophysiologist and direct the Heart and Vascular Institute's cardiac electrophysiology service line. That means the heart rhythm specialty for MedStar Health. And I've been with MedStar for the past 18 and a half years, coming down from Baltimore, from Johns Hopkins, where I did my medical training.
Thanks for joining us. Dr. Meininger.
Hi, Michelle. My name is Glenn Meininger. I'm based out of Baltimore. I'm part of the electrophysiology practice up here. There's 4 of us that work on clinical electrophysiology. I did my training at Johns Hopkins and have been at MedStar really almost the last 20 years.
Thanks for joining us as well. Dr. Bethea.
Hi, my name is Brian Bethea. I'm also a Hopkins trained, but this time a cardiac surgeon. I'm probably one of the few people that actually hasn't come to MedStar and stayed at MedStar. Started off down in Dallas at UT Southwestern, also Baylor, and then was down in Florida for 5 years before returning to Baltimore. I'm the chief of cardiac surgery, specializing in the treatment of valvular disease, both surgically and structurally. And then what follows valve disease is also atrial fibrillation. So a keen interest in helping patients with atrial fibrillation.
Well, thanks again for joining us. And last but not least, Dr. Shults.
Hi, thank you. I'm Christian Shults. I'm a cardiac surgeon for MedStar based in Washington, D.C. I've been with MedStar for the last 9 years. I serve as a co-director for the complex aortic program. Spend a lot of my time working on complex aortic problems. I trained at Emory. I guess I'm the one man out here. Trained at Emory down south, but came up, did undergrad med school and general surgery at Georgetown here in DC. But I've also developed considerable expertise, and I'm also the surgical director for ablation here at MedStar in Washington Hospital Center, and have gained expertise and specific interests in the treatment of atrial fibrillation.
All right, well, thank you again for joining us today. Let's dive into some of our questions. I'll start with Dr. Meininger. Could you share what atrial fibrillation is?
So atrial fibrillation is the most common irregular heart rhythm we see. It has origins both as a consequence of other medical issues, but there are also some lifestyle pieces to it as well. It's generally felt to be disorganized rhythm in the upper chambers of the heart, which are kind of the priming chambers of the heart. People who have atrial fibrillation often are aware of it because they have associated symptoms, shortness of breath or palpitations. And it can be, as I say, as a consequence of having other medical issues such as sleep apnea or obesity or hypertension. But it can also be a manifestation of, drinking too much alcohol or being dehydrated or heavy caffeine use. So it is a very common problem that we see and probably dominates most of our practices in electrophysiology because as the population ages, we see more and more of this abnormal rhythm.
That's interesting. So as we mentioned earlier, 1 in 4 adults over the age of 40 will develop atrial fibrillation in their lifetime. So Dr. Meininger, could you share why AFib is so common?
Well, it's sort of a wear and tear rhythm on the heart. So the longer people live, the more likely they are to experience stress on these upper chambers of the heart. So again, also those lifestyle components also can be a dominant factor. But as we get older, we see more problems with high blood pressure, weight gain, obesity, and then valvular heart disease, which is also, certainly a major contributor to episodes of atrial fibrillation. So when people are at the age of 50, maybe only 1 or 2% of the population have atrial fibrillation. But again, by the time you're reaching the age 80, you'll see over 20% of the population has had episodic atrial fibrillation.
Could you also share what are the symptoms of AFib? What signs should people be looking for? And also, how is AFib diagnosed?
So, fortunately, there are many new strategies for diagnosing AFib. With the pervasiveness of wearing Apple Watch or Fitbit or something called KardioMobile, we're seeing more and more self-documented episodes of atrial fibrillation. For a lot of people, they're fortunate in the sense that they have an awareness of it that can bring the problem up a little bit quicker. And so, but about a third of patients have no awareness of it, and the symptoms can be more subtle. The common ones are sort of a flip-flop in the chest, or some people will describe they feel like they have a fish in their chest, or an uncomfortable feeling in their neck, racing of the heart, sweats, nausea, shortness of breath, swelling in the legs can all be common complaints. Some people will get lightheaded or even have chest pain with episodes of atrial fibrillation. But again, about a third of people, it's found incidentally. It's not something that they can easily describe a symptom related to, but rather just see rapid heart rate or irregular heart rate on a monitor.
Okay, yeah, that's a little scary, knowing that the symptoms can be subtle. So thank you for explaining that, Dr. Meininger. So does AFib also does having AFib also put someone at risk for other adverse health conditions?
Sure. So why does AFib matter? And really the big issues are that atrial fibrillation can create symptoms that can impact quality of life. But the big issue that we're really focusing on is that it can also lead to risk of stroke. It can lead to development of weakening of the heart pump or cardiomyopathy. And so, and it can also be a sign or an indicator of structural heart disease. So the key is once we start seeing AFib, we have to go a little deeper into understanding why somebody is having episodes. Is it purely a lifestyle? Or is it related to some of these other concomitant conditions? And then most importantly, is there a structural component related to the heart that all need to be addressed? Generally, once we identify atrial fibrillation, it doesn't go away on its own. There is usually some treatable factors that we need to kind of lay out and address and target in turn. And for many people, AFib untreated can progress and can snowball into more episodes of AFib and then downstream effects. So one is we're doing a better job of identifying it. We're finding patients earlier. Now we're focusing on trying to treat patients earlier. And one of the advantages with the therapies that we have available now is we can treat people in the beginning spectrums of atrial fibrillation, but now we have therapies that offer treatment at the very end stages, even as people are more persistently out of rhythm and go into more chronic atrial fibrillation or permanent atrial fibrillation.
That's good to know. I like that we're having sounds like a proactive approach to catching this disease. So thank you, Dr. Meininger. At this time, I'd like to pull in our other cardiac electrophysiologist, Dr. Zayd Eldadah. So Dr. Eldadah, are there could you share what are the different types of AFib? Dr. Meininger sort of alluded to this earlier, but could you share and describe the different types of AFib?
Sure, of course. So just by way of review, remember that atrial fibrillation means that the normal heart rhythm in which the upper chambers of the heart squeeze rhythmically, pushing blood into the lower chambers of the heart, get hijacked. They get hijacked electrically. So the upper chambers, instead of squeezing in a normal way, start to quiver. And many situations can lead to that. So there are two broad categories of atrial fibrillation. One is what we call acute atrial fibrillation. And basically, any acute insult on the heart can cause the atria, the upper chambers, to fibrillate, like excessive caffeine, excessive alcohol, high stress, being up all night, sleep deprivation, thyroid hormone surges. So a lot of discrete events. They're not happily received by the heart muscle, and the heart muscle's response is to fibrillate the upper chambers. Those are fairly straightforward because that category of atrial fibrillation, or acute atrial fibrillation, resolves completely if you just fix the underlying cause. Get the sleep, stop the caffeine and the alcohol binge, etc., and the AFib goes away. What we're really here to discuss is the second category of atrial fibrillation, which is non-acute atrial fibrillation. As Dr. Meininger was explaining, that's the atrial fibrillation that we see as human beings age. So the numbers are quite staggering. It's probably closer to a third of humans anywhere in the world, all over, no matter where, at some point in life will have atrial fibrillation. And it's a phenomenon that's primarily driven by the aging process and genetics. When we talk to patients, a lot of times we say, when they ask, well, why did I get atrial fibrillation, doctor? And our response is actually probably fundamentally for the same reason that we're getting gray hair. The same process that causes our hair cells to lose the ability to form pigments and color our hair is happening in the heart as well. And their heart muscle changes that result in this electrical derangement process. So non-acute atrial fibrillation is associated with aging and genetics. Some people get it earlier than others. By the time we're 80, maybe 20–25% of us will get it. And our whole lifetime risk is probably closer to about a third for all human beings. Within that group of aging related, the more common atrial fibrillation that probably right now affects 10, 12, 15 million Americans, there are subtypes of how the atrial fibrillation presents. So doctors will tell patients you have a presentation of atrial fibrillation that is paroxysmal. That simply means the episode of this electrical hijacking, the abnormal rhythm, happens and then goes away on its own. Happens and goes away on its own. And we even give a time frame for that the duration of the episode is less than a week. So it can be a few seconds, a few minutes, a few days even, but always less than a week before it spontaneously reverts to normal rhythm. That's called paroxysmal or episodic atrial fibrillation. This next type of this non-acute aging-related atrial fibrillation is called persistent atrial fibrillation. And that means that the episode that happens stays present for at least a week, and something needs to be done to get the patient out of that abnormal rhythm, typically an electric shock, we call that a cardioversion, or a medication. But if the episode lasts longer than a week and requires an intervention to restore normal rhythm, we call that persistent atrial fibrillation. And then the third category, and we're going to spend more time talking about this today, is called long-standing persistent atrial fibrillation. And that's in which the episode occurs and is present 24/7 all the time for at least a year. We call that long-standing persistent AFib. It's the more advanced stage of AFib. The simple last little way to remember this is if you think of gray hair, it starts off a strand here and there, then gets more pronounced. Then if you let it go long enough without doing anything about it, the whole hair will turn gray. Similar phenomenon. Last example is dandelions. They start in your garden here and there, occasionally, episodically. And if you let it go, the end stage of that is the entire lawn is taken over. And the reason for that progression is that when atrial fibrillation happens and keeps happening, there are structural changes in the heart that get accelerated, and that promotes more atrial fibrillation, more structural change, more atrial fibrillation, and what we define as the long-standing persistent or the last stages. So what you were saying, Mashan, earlier, which is that it's so important to recognize this early and take a proactive approach so we don't get to that late stage.
Absolutely, absolutely. Thank you for describing that. I like the visuals. It helps me get a better picture of what's going on in a patient's heart and the progression of AFib and the different types. Dr. Eldadah, could you also share, now that we know that there are different types of AFib, could you share the various treatment options that are available for atrial fibrillation?
Of course. So one quick thing that we'd like to share is that atrial fibrillation probably shouldn't be thought of as a disease. It's not a discrete infection or disease or tumor that you fix and it goes away. It's not the way to think about atrial fibrillation. We have to think about it, again, this category of AFib that we're here to discuss, the more progressive aging-related atrial fibrillation as part and parcel of the aging process. So the big category of how to intervene is to age better. That means to be healthier. So ways that we can make ourselves healthier are the number one intervention that we can do as individuals to help blunt this otherwise inexorable march of an aging-related process. So that means eating right, keeping our weight down, exercising, staying healthy, not abusing alcohol or drugs or tobacco or caffeine even. Just the kind of way that your mother would tell you to live is the number one way to intervene and make the AFib process slower, less intense, and ideally so slow that we may not see it at all in a typical lifetime. But when it's developed, we still should try to live healthy. And then there are other ways that medical technology can help us. And so one of the simple ways that we deal with atrial fibrillation is to, first and foremost, as Dr. Meininger said, evaluate for the risk of a stroke. Not all people have the same risk of stroke, but once there's an evaluation of stroke risk, there has to be therapy if needed that's done. That's typically done with blood thinners or an equivalent. That's taken care of, that takes care of the elevated risk of stroke that atrial fibrillation presents. But when it comes to the rhythm itself and trying to blunt this process so the dandelions don't multiply in your garden, the gray hair doesn't multiply, the AFib doesn't get more pronounced and alter the heart, we can do a number of things. We can use medications to help make the episodes of atrial fibrillation less frequent, less severe. And medicines are okay. We have a handful available to us. They have their pros and cons, but that may be what the doctor recommends. There's another intervention called a cardioversion, which is an electric shock that can be delivered to a patient's chest. It's done under a controlled setting, typically in a hospital with anesthesia to put the patient to sleep. And then a quick electric shock restores normal rhythm. That's kind of like a computer reset, switching on and off your computer when it starts to malfunction with a virus. It's a quick fix to get the patient back rolling again. And then we have more involved interventions such as catheter ablation, which is a technique to actually modify the heart muscle and make the AFib less likely. And then we're going to spend some time today with our surgical colleagues, Drs. Shults and Bethea, talking about a surgical plus catheter technique that can be done for patients with more advanced forms of atrial fibrillation. So several ways we can intervene. First and foremost, live healthy, but also an electric shock therapy, medical therapy, catheter-based therapies, and hybrid approaches with catheter plus surgical therapy.
All right, thanks, Dr. Eldadah. Good to know that there are multiple options for treating AFib. I'd like to bring in Dr. Meininger again. Could you share what is longstanding persistent AFib and how it's different from conventional AFib?
Sure. So, I know that Dr. Eldadah went through sort of the various stages of atrial fibrillation. Longstanding persistent is, for many intents and purposes, felt to be kind of towards the end of the progression of atrial arrhythmia. Often it occurs in the setting of patients that have had intermittent AFib, maybe unrecognized or persisting over years, and then remodeling changes in the heart itself, and in particular the atrium, which is a smaller structure than the bigger pumps of the heart, the ventricles, and it can lead to stretching and enlargement of the chamber. Those remodeling changes then lead to more permanent or persistent arrhythmia. And again, typically when patients have been out of rhythm for over a year, we call it longstanding persistent atrial fibrillation. And it's important to note that distinction, because for years, there has been no great therapy to manage these patients. And so the evolution over time has been, what strategies can we offer? Is there still hope to maintain normal rhythm despite having both the remodeling changes in the atrium and the longstanding persistent arrhythmia? What can we do to that group of patients? So that's where kind of newer novel therapies such as hybrid ablation and other strategies have come come along to try and help provide some benefit and advantage for that group of patients.
All right, thank you. Could you also share how prevalent longstanding persistent AFib is? We talked about how common, conventional AFib is. 1 in 4 adults over the age of 40 could develop this over time. How prevalent is the longstanding version of this?
So this is sort of what we would say is more end-stage atrial fibrillation. And because of the fact that there has been no great therapy for this group of patients in the past, many patients have been in longstanding persistent AFib for years. All in all, it probably accounts for about 10% of patients with atrial fibrillation. Again, the hope is that we are now intervening earlier on patients with atrial fibrillation. So over time, we hope to have an impact on the prevalence of longstanding persistent atrial fibrillation. But on the flip side, population is aging. So we have more and more patients that are presenting at a later stage in life, and we want to be able to offer therapies to that group as well.
Thank you, Dr. Meininger. I'd like to pull in Dr. Eldadah again. Could you share the treatment options for longstanding persistent AFib and how they may differ from conventional AFib treatments?
So again, just to reiterate, longstanding persistent atrial fibrillation reflects a more end stage or progressed stage, just more advanced, which means that the tissue or the heart muscle itself, in particular on the backside of the heart, the left upper chamber's backside changes in character from being a healthy young muscle to being a more older, scarred tissue, and more work, if you will, needs to be done for patients who have that form of atrial fibrillation. The estimates actually may be that that is a very large proportion of the overall number of people who have atrial fibrillation, because again, as people age and we're able to live longer, we can live with atrial fibrillation. It's just not living great. That's why we were here to talk about ways to live better and help hopefully reverse this process. But the numbers may be close to 40 to 50%, 40, 45% of the global atrial fibrillation burden is that category of longstanding persistent atrial fibrillation. And our techniques to restore normal rhythm in those patients are limited and have been up until more recently when we've learned about new technologies, and we're going to talk about that. But our historic techniques have been to convert the patient with an electric shock, cardioversion. That might work very briefly, but typically by the time longstanding persistent AFib has in place, meaning atrial fibrillation for more than a year constantly, the heart muscle has gotten used to atrial fibrillation and will often flip right back after a cardioversion. Medicines can also be used, but similarly, they're generally not very effective because the heart has gotten so used to fibrillating, so changed structurally that the medications generally don't have great effectiveness. Catheter ablation has been used in these patients. A lot of ablation needs to be done. A lot of tissue actually needs to be addressed by the ablation technique. And catheter ablation works in these patients probably better than medicines do and any other therapy does for that degree of invasiveness. And catheter ablation is not considered a very invasive therapy, but it's limited in what it can do. Perhaps at best in people in this category, 50, 60% of them might have very good relief with a catheter ablation procedure, but that leaves a lot to be desired. So really what we're here to discuss is what to do in those patients who are not achieving good results from other techniques or want a technique from the get-go that's a better option. And that's known as hybrid ablation or convergent atrial fibrillation ablation. I'll just introduce it by the name, and we're going to spend some time with our surgeon colleagues to talk about the actual technique.
Thank you, Dr. Eldadah. I think that's a great segue. Thank you for joining us. So if you're just joining us, thanks for tuning in. My name is Meininger Carter, and I'm here with our cardiac electrophysiologist, Dr. Zayd Eldadah and Dr. Meininger. and also our cardiac surgeons, Dr. Brian Bethea and Dr. Christian Schults. So did you know that 1 in 4 adults over the age of 40 will develop atrial fibrillation or AFib? It's an irregular heartbeat. So in honor of American Heart Month, we're discussing what AFib is, the different types and ways to treat it. So we have more to discuss. So stick around, share this broadcast with your friends, give us a like to let us know that you're here and you're watching. And if you have any questions, please share those in the comments below. So at this time, I would like to spend a little bit of time on some of our audience questions. We have quite a bit, so thank you all for tuning in and sharing these with us. So first, I have a question from Linda, who is asking, if you've had an ablation procedure and was told that it was successful, do you still need to stay on blood thinners? And if yes, why?
So I'll tackle that.
Okay.
Right now, guidelines still recommend that patients' decision on blood thinners pre-ablation and post-ablation are the same, meaning that if you have high risk for stroke and you are ablated and felt to be ablated successfully, guidelines now recommend that you still stay on that blood thinner based on your stroke risk profile. And the reason being that while all patients who are ablated, many are successful and have no further episodes of arrhythmia, there is still a risk of recurrent arrhythmia, and your risk is likely higher than somebody who's never had atrial fibrillation. That being said, people who are at lower risk, it may be an opportunity for us to reconsider the need for long-term anticoagulation. And there are newer studies that are looking at, are there subgroups in patients post-ablation who are successfully able to be maintained in normal rhythm? Can we come off blood thinner? But as of now, the guidelines really are more focused on what is your risk profile, assessing something called the CHADS-2-VASc score, which incorporates stroke risk parameters as to the determination of staying on blood thinner or not on blood thinner.
Okay.
I would just chime in one more thing just to
Sure.
make things clear for patients. When we talk to them, we want to be very clear. What we know already is that once somebody has atrial fibrillation that keeps coming back, the aging-related atrial fibrillation, stroke risk goes up. How high up beyond that is, like Dr. Meininger said, based on other factors that the patient may have. That's what defines the actual likelihood or risk of stroke in a given year. It's important to remind patients that it's those factors which elevate the risk of stroke further, not how little or much atrial fibrillation one has. Whether one has atrial fibrillation all the time, or once every few months, or once every few days, or every few hours or so. The AFib can be very variable, and therapy can be a way of making it less frequent, but that doesn't affect stroke risk, we don't believe. Stroke risk is defined by other things. So that's an important point to make. Stroke risk isn't directly connected to how little or much atrial fibrillation one has. It's almost counterintuitive, but it's an important point. So to answer the question is, for now, stroke risk is an independent problem that needs to be addressed to keep you safe, whether or not we can see evidence of the atrial fibrillation on an EKG or monitor.
All right. Thank you very much to both of you, Dr. Meininger and Dr. Eldadah. And thank you all for tuning in and sharing your questions with us. We will get back to those as soon as we can. So I'd like to turn to Dr. Schults and bring some of our cardiac surgeons in for the discussion. Could you talk about hybrid AF convergent therapy, what that is and how that procedure works?
Sure. So thank you. So, as was mentioned, there are several types of AFib, and the persistent, long-standing persistent is generally, it's a very difficult group to treat. From the surgical world, we have very effective treatment for patients. It's called the Cox maze. It's a full biatrial ablation, but that's typically used in patients who are already undergoing heart surgery. Meaning, if all you have is AFib, most patients, most doctors don't want your chest open, go on the heart-lung machine to be treated for AFib. But recognizing the effectiveness of that therapy, several years ago, a group looking at this problem, how can we effectively treat patients with persistent, long-standing persistent AFib. They developed this new procedure called hybrid convergent, which we're talking about today. And the goal is to try to take as much as we can from the open surgical therapy ablation and deliver it in a way that's minimally invasive, as least invasive as possible, with minimal risk, minimal morbidity, and to try to deliver that same effective therapy, but in a much less invasive way. And that's what spawned this convergent hybrid ablation. It was introduced at the hospital center and in MedStar about 11 or 12 years ago. We've been doing it for a long period of time. But what it entails is, and it's not a complete Cox maze, but what was recognized is that the majority of the AFib that occurs in persistent, long-standing persistent, the origin of that often is centered in the posterior wall of the left atrium. So the rationale is if we can ablate that posterior wall of the left atrium and combine it with the catheter ablation to provide a pulmonary vein isolation, that we could deliver more effective therapy. So we've been doing it for many years until finally we did a trial about a couple of years ago. The company that came up with the procedure sponsored a trial called the Converge trial, where we compared head-to-head 2 versus 1 hybrid ablation with catheter ablation in patients with persistent and long-standing persistent AFib. And in both categories, what was shown is that there's statistically significant improvement in outcomes for patients with both persistent and long-standing persistent atrial fibrillation. Now, the difference or the delta between those two groups was substantially larger in the long-standing persistent AFib. And that's why the FDA approval was issued for long-standing persistent AFib. But it's also an effective therapy for persistent AFib, in particular patients who've had 1, 2, 3 ablations, and honestly, also in paroxysmal AFib. A number of patients, even with paroxysmal AFib, can benefit if they failed an ablation 1 or 2 times, can also potentially benefit from convergent ablation. But let me back up. What this entails from a surgical perspective is it's a small incision just below the breastbone. It's called the xiphoid process. It's that little prominent piece of bone at the bottom of your sternum. We make a very small incision, about 2 to 3 centimeters, get in the pericardium, which is a sac that surrounds the heart. And with a scope and a cannula, we ablate that whole posterior wall. Now, we've also added a clip in most patients, which is a thoracoscopic clip, meaning 3 small incisions between the ribs. We open the pericardium, put a clip on the appendage. And that is done to minimize your stroke risk. Again, that's the kind of the biggest risk of having atrial fibrillation stroke. So delivering the ablation of the posterior wall plus the clip to treat the AFib as well as to minimize your stroke risk. And then that portion of the surgical portion of the convergent hybrid ablation is complete. And then after that, usually 1 to 2 months later, our EP colleagues will take the patient back to the EP lab and then perform their procedure. I don't know if Dr. Eldadah maybe wanted to talk about that, but let me just make one more comment. Sorry, the part of the reason why this becomes kind of front of mind, this convergent hybrid ablation, is because the FDA approved this procedure about a year and a half, 2 years ago, and as a result, there's been a lot of interest. But I just kind of wanted to make the point that this is something that credit to Dr. Eldadah and his team, who very early on, 12, 13 years ago, recognized the need for something more effective and kind of brought this procedure to MedStar. And we've kind of together built this program to be very robust and one of the most experienced centers in the world, frankly, for delivering this therapy. So I don't know, Zayd, if you wanted to talk about the catheter EP portion.
Sure, thanks, Christian. Yeah, so the nice thing about this procedure is that it's called convergent atrial fibrillation ablation, or convergent therapy, because we converge 2 ways of approaching the tissue: from the outside of the heart via the surgical technique and the inside of the heart via the catheter technique. A catheter is inserted in the large vein in the thigh, and it gets access to the left upper chamber of the heart where the work is done. And we did our first case actually in December of 2011. And as Dr. Shults has mentioned, because we wanted to find a better approach for patients for whom existing therapies were just not enough and the problem of atrial fibrillation continued. And our side, or the electrophysiology catheter-based side, simply involves the traditional catheter ablation. But because it's done after the surgical work happens, we're able to map with very high resolution and identify what parts of tissues in the heart, what areas of tissue within the heart still need therapy, which we can try to deliver from the inside of the heart. The last comment is that one of the reasons we feel this approach is so effective, in addition to bringing surgeons and catheter doctors together, both for the patient's best interest, is that we're actually able to sandwich both sides of the heart, because the heart muscle actually has some thickness to it, and parts of the muscle are not accessible if you purely approach it from the inside, and parts are not accessible if you purely approach it from the outside. But when you approach from both sides, you're able to get all the territory that needs to be addressed.
That's really fascinating. That's good to know how well you all work together in order to help our patients. So thank you very much for describing that whole process. I'd like to bring in Dr. Bethea. Could you share more about hybrid AF convergent therapy? Is that now the treatment of choice for AFib patients?
Well, it's interesting. And I think, just to kind of summarize for the patients, things that we've learned thus far that have been discussed is that we know that atrial fibrillation is bad. This is something that Dr. Shults and I have known for a long time in the surgical world. And oftentimes new technologies are spawned from lessons learned either in an analogous discipline or a completely different discipline in medicine. And what we've heard is that AFib is a progressive disease, that once you start developing AFib, it's going to continue to progress for your lifetime. There was a recent trial that came out that showed that early intervention with a catheter was clearly better than taking medications for atrial fibrillation. Therefore, we're talking about long-standing, persistent. Dr. Shults mentioned potentially attacking paroxysmal AFib. I think eventually that's where this field may go until there is a endotherapy, meaning a catheter-based therapy, which can mimic as close as possible to current day Converge, but then historically the Cox-Maze-4. What we know in the surgical literature, it doesn't matter if you're getting bypass surgery, if you're getting a valve repaired or replaced. If the surgeon at the time doesn't address the atrial fibrillation, your life expectancy is significantly decreased. And it's the same difference as if we don't use the internal mammary on a CABG and we use all veins, is the same as ignoring atrial fibrillation. So we are doing a trial right now that is looking at patients with long-standing persistent atrial fibrillation that have not had a catheter ablation. So hopefully we will get those results in a couple of years' time. And I think that will be the beginning to even more partnership. But I think my encouraging message to the patients is that if you have atrial fibrillation, I think you need to seek a consultation with a specialist. And usually that specialist starts with not either, but usually with one of our EP colleagues. And it can be Dr. Meininger, Zayd, whoever it may be, whoever's closest to you, but you really need to see a center that's focused in atrial fibrillation, that understands what is the long-term effect. I see a lot of the downstream effect of atrial fibrillation. I see a lot of the cardiomyopathy or the reduced heart function of the left heart from constantly having what we call a tachyarrhythmia or fast heart rate. I also get involved in a lot of cases that where the ventricle has dilated from atrial fibrillation that stretches on the mitral valve and causes mitral regurgitation. But the upper chamber can also dilate. Zayd's shown you the model several times, but that can also put pressure on the mitral valve, which lives between the top and bottom chamber of the heart and can also cause mitral regurgitation. And in transcatheter world, oftentimes the ones that are just the top chamber, we use a MitraClip. If it's the bottom chamber, we replace the whole valve. And I can tell you that patients, once we start manipulating their mitral valve, they don't do as long-term as somebody who's never had mitral valve disease. So again, I think the take-home message here is if you have atrial fibrillation, seek a consultation. And in terms of the Converge procedure, it does, as Dr. Shults mentioned, mimic the closest thing current day technologies that we have that can mimic the Cox-Maze-4, which has undergone the reason why it's called 4 is because Jimmy Cox went through multiple iterations of this operation and studied this. This is his lifetime passion to try to provide patients the best possible chance of living life without atrial fibrillation.
Thank you, Dr. Bethea. Continuing on with the convergent therapy, is that procedure widely available, or do certain hospitals or health systems offer it now?
I would say, it's kind of shocking to me, knowing what we know about atrial fibrillation, how few surgeons are actually interested in doing this. I think that they are busy doing other cases, or maybe they don't quite understand the impact of atrial fibrillation on patients. If you look at our national society and our database, when somebody comes in with atrial fibrillation and needs another procedure done, the range of the patient actually getting an atrial fibrillation procedure is somewhere between 15 and 30%. So I think Dr. Shults and I are in the minority of surgeons who understand the gravity of atrial fibrillation, what it means to the patient long-term. We're not talking about today or tomorrow, but we're talking about helping you live 10 to 20 years is how I always approach the patients. So currently in the Mid-Atlantic region, it's really the hospital center and Union Memorial here in Baltimore that are the most aggressive in the management of atrial fibrillation from a surgical standpoint.
All right, thank you again. And more on that type of therapy, could you share, describe it, and what's the typical hospital stay after the procedure? How safe is it? What are the risks that people need to consider?
Sure. Dr. Meininger and I do it a little bit different than they do now at the hospital center. In the trial, you'll come in at 7 o'clock in the morning and I'll do my part, and then you'll go directly down to the cath lab and Dr. Meininger will do his part, usually around 10:30 or 11 o'clock in the morning. So that's a one-stop shop if you're in this new trial that I mentioned. If you're not in the trial, we generally do them late in the day, usually around 1 o'clock or 3 o'clock in the afternoon. You'll stay overnight. You'll have a small drain from where we put the camera in. Then Dr. Meininger will do his part the next morning. We watch you for one night because the biggest risk with this procedure, in my mind at least, is developing a pericardial effusion. That's why we leave the drain in. And then the next morning we pull the drain. You get an echo 4 hours after the drain, usually around noontime, and you're usually in your car heading home around 1, 2 o'clock. We do give you prednisone for a month just to kind of quell. We always cause inflammation of that sac that lives around the heart that was mentioned. And so that's really the biggest risk. We see delayed effusions. And so we put you on a month of prednisone. And if you have diabetes, I'm sure that some people are like, well, I have diabetes, I don't want to take prednisone. We actually have our endocrine specialists see while you're in the hospital, and they follow you during the titration period so that we don't run the risk of causing you hyper or hypoglycemia.
Okay, that's good to know. And could you also share more about the outcomes of this procedure? Will it cure the long-standing persistent AFib?
Well, I don't think that we have long-term enough data to be able to confidently say that, but it does give us our best opportunity. I think is probably the most fair way to view this technology.
Okay, well, that's encouraging news to know. So thank you, Dr. Bethea. I'd like to bring in Dr. Shults again. To share, are there any certain patients who are better candidates for this procedure than others?
Yeah, so kind of coming back to a common theme is, the earlier you get treatment for your AFib, the better. There's a saying that AFib begets more AFib, and Dr. Eldadah and Dr. Meininger kind of very clearly explained that, the longer you're in AFib, your heart changes, the structure of your heart can change as a result. So, and to echo Brian's point that, that if you have AFib, it really is behooves you to have an evaluation by one of our electrophysiologists. But, I think that, ideally this is kind of most commonly, I guess, for the patients that I'm seeing are patients who've been under treatment. They've had maybe 1 or 2 ablations. And from an EP perspective, the feeling is that, doing another catheter ablation really won't add much. And in that scenario, that most commonly, those are the patients I see for the convergent hybrid ablation. But there's also, and we've also seen shifts now with FDA approval, that for patients with long-standing persistent, instead of going to catheter ablation, just go straight towards convergent. knowing that it's a better option. So, I mean, I think, there are patients, obviously, the larger your atrium, the longer you've been in AFib, the more likely you are to not have a successful outcome. But that being said, I don't put strict limits on time of AFib or left atrial size necessarily. I really think, in terms of which patients I would not do this surgery on, we've also been doing it on patients who've had heart surgery before. That's something that I think is a little unique to our center. So I think, quite frankly, almost all patients that have come my way, get an evaluation. And it's very rare that I would not offer this therapy to a patient, just because I think it's broadly applicable.
All right. And that answered my next question, would have been my next question about other, what are those considerations to make when you evaluate a patient? So good points to think about. So thank you for that. I'd like to bring in Dr. Eldadah at this time. Are most cardiologists aware of this treatment for AFib?
So it's interesting that the cardiologists all over have different practice styles. Some cardiologists focus in some areas more than others. Some are particularly attuned to the literature in certain areas than others. So it's hard to make sort of a blanket evaluation of cardiologists all over. I think our goal is to recognize that medicine and the way we care for patients is constantly evolving. We're learning new things all the time. We're throwing away things that turn out to be untrue, adding new knowledge, revising that knowledge. And I think our discussion today is an example of that we're here to discuss a problem that's a healthcare challenge because it's so pervasive and widespread and growing, and it's really just part and parcel of the human aging process. 100 years ago, we saw very little atrial fibrillation because people weren't living generally beyond 50 years or 60 years of age. Now that we're living longer, we're seeing more atrial fibrillation. In the years to come, we'll probably see more. So our hope is that we can share information from programs like this, encourage our colleagues in the cardiology community and the internal medicine community to talk to people who deal with atrial fibrillation a little more commonly, people in the specialty that Glenn and I share, and to some extent, I think that Christian and Brian share on the cardiac surgery side. We've all become de facto atrial fibrillologists because there's so much atrial fib out there. This is what we deal with every day. So it's easy for us to talk about something we see every day. But if a cardiologist doesn't experience this every single day or deal with it, an individual may not see the options as others might. So our goal is to get the message out, encourage people to talk, collaborate, review what's in the literature, and hopefully we can answer questions and see if a particular therapy may be right for an individual patient.
All right. Thank you, Dr. Eldadah. Dr. Meininger, I'd like to bring you in at this time. Is this type of therapy, is this something that a patient could bring up with their primary care physician if they have long-standing persistent AFib?
Yeah, I mean, absolutely. I think that the unfortunate thing is that because therapies were not as available in the past, many patients have sort of brought this up to physicians along the way, and really their impression is that there is no further option. I think, unfortunately, now our task is to continually educate physicians that there are new therapies that are becoming available year in and year out. So don't give up hope on treatment options. Certainly bring it up to your physician or your cardiologist, or seek out an opinion from an electrophysiologist. I think people look at things a little differently, and I think they look at things differently based on life experience. And we're kind of in the trenches in managing atrial fibrillation, so we are at the forefront of what options are available. And I think that that is certainly something that we want to make sure people know about.
All right, thank you, Dr. Meininger. I'd like to bring in Dr. Bethea as well. So after the procedure, do patients still need to take blood thinners? I think we had an audience question as well related to that issue.
Yeah, we do keep you on blood thinners, especially to minimize the risk of any thrombus or clot forming related to the procedure itself. And then long-term, it goes back to the initial comments and conversation that we had, that it will then depend on your stroke risk. Say if you were in sinus rhythm, we would evaluate your stroke risk moving forward in your lifetime. I think Zayd made a very good point that these are two independent things. Just because we take care of the atrial fibrillation doesn't mean that we've eliminated your stroke risk. And so your doctor will evaluate that and decide whether you continue to stay on the blood thinners or not.
Okay, and also related to that, will patients need a follow-up procedure, or do they need to take any medications for AFib after having the procedure?
Well, hopefully if things go our way, right? I mean, if it's successful, but that's really kind of unpredictable. And again, in our world, we like 10 and even, further out data, and we just don't have that yet. So it's hard to answer that question with 100% certainty.
All right, thank you, Dr. Bethea. I would like to dive into some of our audience questions. So I will go back up to those. So we have a question sort of related to medications. So this one comes from Clara, who's asking if the AFib is able to be mostly controlled by medications, meaning the AFib is 5% or less of the time. What is the downside of not doing an ablation, particularly if the patient will still remain on blood thinners if the ablation is successful? So any of you can take that question if you feel free.
So that's a very good question. And I think it highlights something that's very important, which is that the practice of medicine and taking care of atrial fibrillation must be individualized. We don't have a one-size-fits-all formula where everybody gets plugged into the same treatment algorithm. No. For a given individual, a discussion with specialists and your doctor is the way to achieve the best course of action. So for this particular scenario, if it's truly the case that the atrial fibrillation is being kept at bay, where 95% of the time normal rhythm is present and atrial fib is only there occasionally, about 5% of the time, it may be very reasonable just to continue a what we call rhythm control approach or suppression of the AFib with gentle medicines, while of course protecting against the risk of stroke, and maybe holding off on a catheter procedure or an ablation procedure. That might be very reasonable, but with good follow-up, because what we generally know is that atrial fibrillation usually doesn't stay static. Just like gray hair doesn't stay the same level for the rest of life. It generally progresses over time. So that 5% may, over the course of time, become 10% atrial fibrillation, then 15%, then 15%. But the rate at which it does that can be very variable and differ from person to person. So a tailored approach, an individualized approach, but it doesn't always have to be an interventional approach.
All right, thank you very much. I have another question from Donna and one from Linda. So these are both medication related. So Donna is asking, are there any medications to prevent AFib? And also from Linda, what is the best medication for AFib?
So I guess I'll tackle this one. In terms of the best medications for AFib, again, one is protecting against one of the consequences of AFib, which is stroke risk. And there are, the guidelines now recommend a group of, or a class of medicines called DOACs, which are essentially drugs that are aimed at preventing risk of a thrombus forming or clot forming. But in terms of in terms of managing AFib and preventing AFib, there's a class of drugs called antiarrhythmic drugs. And even before that, there's a type of drug that can help limit, or a mild rhythm stabilizing drug. The names of those drugs can be beta blockers or calcium channel blockers. But when you get into that next tier of what we really term rhythm stabilizing drugs or antiarrhythmic drugs, there are a class of drugs that we can choose, and it's very specific in which drugs we use based on other conditions. So certain drugs we can only use in certain patients. We have to take into account a patient's kidney function, whether they've had prior heart attack. But these drugs, as our earliest or our earlier question had alluded to, these drugs may be very helpful in maintaining rhythm. And for some people, it is the right initial strategy. And we sort of explore those options with every patient when we're contemplating choices of next steps. There is no magic bullet, and many of these rhythm stabilizing drugs, while can help protect people against atrial fibrillation, they come with a potential risk as well. Not that drugs are a clear, safe alternative to a procedure. Sometimes the procedure offers the best of all worlds, and for some people it is the drug. So unfortunately, I can't answer that as a single, sort of silver bullet drug that will help manage atrial fibrillation, but certainly that is part of the armamentarium we use to treat and manage atrial fibrillation.
All right, thanks, Dr. Meininger. So as we close, I would like to go around the room and get your feedback from each of you physicians. So is there any other information that you would like to share, whether about atrial fibrillation or longstanding persistent atrial fibrillation? Any things on the horizon that patients can look forward to in terms of treatment, any preventative measures, anything like that? So I will start with Dr. Shults.
Thank you. I think probably one of the most important take-home messages is that of, if you do have AFib and it has not been evaluated, or you feel like you would like another evaluation, you'd like to see if you're a candidate for a procedure, or maybe you're unhappy with your therapy, or you want to just generally know, are there other therapeutic options available? Please, consult with us, with Dr. Eldadah or Dr. Meininger's teams, because I think that there, and we touched on this. It's highly variable in the cardiology and medical community. Practice patterns, for example, and the age-old strategy, just rate control and anticoagulation. It's effective in many cases, but there's a lot of options available that a patient can avail themselves of. So that's, I think, probably the biggest take-home message. And should you need a hybrid ablation, just I want to emphasize again that it's a very low-risk procedure that on balance, compared to all other options, is very effective, and would be happy to help you if we can.
Thank you very much. Dr. Eldadah.
To echo what my colleagues have said, the simple message is that atrial fibrillation is a mark of the aging process. It's nothing to be upset about, alarmed about, ashamed about, but it's something to pay attention to. Not all people will experience it the same way, either with symptoms or consequences of it, but everybody should take it seriously, just to be proactive. And first and foremost, be proactive with your health. Age well, live better, eat right, keep your weight down, exercise regularly, avoid things that put toxins in the body. And if atrial fibrillation develops and becomes noticeable or detected, see your doctor to talk about options to both protect you against the risks of atrial fibrillation and also protect you against the symptoms and the risks of progression of the atrial fibrillation. Thankfully, we have better technologies, better understanding now than we did before. And in the future, we'll have even more technologies and understanding. So talk with your doctor, and hopefully we can all do our best to help you.
Great, thank you. Dr. Bethea.
So I think, again, I think it's just emphasizing that atrial fibrillation, when it goes on long enough, has several negative effects upon the heart, that are serious, and that you should seek evaluation. Heart failure, dilation of the chambers, valvular disease, these are all, and then are all consequences of atrial fibrillation. And then you've heard us mention stroke over and over, and I don't think that we can talk about atrial fibrillation without mentioning that left atrial appendage management, which is sort of like Snoopy's ear that hangs off the back of the heart. And that's where about 90% of the clot forms in patients with atrial fibrillation. There are excellent options for that. There's a Watchman device, and now there's an Amulet device. And I know Dr. Meininger and Wong here at least Union Memorial are very thorough in evaluating those kind of patients. So there are many options to help you with your global care of atrial fibrillation, not just the rhythm. And I think I want to emphasize that. And that's yet one more reason you need to seek consultation with Dr. Meininger and his team.
All right, and last but not least, Dr. Meininger.
Yeah, I mean, the main take home is that atrial fibrillation has a breadth of options for managing it. And, both on the front end, treating it earlier, identifying it earlier, and the back end, treating it for people that have been told they have no options. I really believe that everybody who has atrial fibrillation has benefit in seeking consultation with electrophysiologists, because it is really the rhythm we manage all the time. And there are a lot of nuances to the approach and treatment. And again, don't be discouraged if somebody has told you there is no option. If you've had a failed ablation, if you've failed drug therapy, if you've had bleeding on blood thinners, there are many things available to treat it. And there are no dead ends in medicine. We just are all really focused on trying to improve quality of life. And this is really a disease that, more than anything else, is about maintaining good quality of life and getting people back to doing the things they want to do.
All right, well, thank you very much. That is all the time we have for today. Thanks to Doctors Eldadah, Meininger, Bethea, and Shults for joining us and spending your day with us. And thanks to all of our viewers for tuning in and sharing your comments and questions with us. For those that we did not get to address during the Facebook Live, we'll make sure to get back to you as soon as possible with responses from each of our physicians. So for more information, or if you'd like to schedule an appointment with us, please call, if you're in the Baltimore region, 410-554-6727, or if you're in the DC region, 202-877-7685. We'll also put that information in the comments below. So thanks again, and we'll see you next time.